Good afternoon, everyone. Welcome to the Disability Competent Care Self-Assessment Tool webinar, where we'll be introducing our updated resource. My name is Jessie Mikulak, and I'll be getting us started today. If you have any questions now or throughout the presentation, please feel free to enter them into the Q&A feature on your platform. We'll be addressing your content-related questions during the discussion portion of this webinar. The Lewin Group, under contract with the CMS Medicare/Medicaid Coordination Office, partnered with Christopher Duff and other disability practice experts to create the resource we're excited to introduce you to today, the DCCAT. As I mentioned, this webinar will be interactive with 45 minutes of presenter-led discussion, followed by a 15-minute presenter and participant question and answer session. We will be offering a video replay, and the slide presentation will be available after the session. You can find those at our website, resourcesforintegratedcare.com. This webinar is supported through MMCO to ensure beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to Medicare and Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful innovations in care models, such as this webinar. To learn more about current efforts and resources, again, feel free to visit our website, Resources for Integrated Care, at the link on your screen. I'll now hand our presentation over to your moderator for today, Chris Duff.
Thank you, Jessie. I appreciate the introduction. We have a very packed webinar today, so I'll just briefly review the agenda. We will start with a quick orientation to the DCC model of care, reviewing the evolution of the model and the 7 pillars. We will proceed to explain how to use the self-assessment tool, which can be found at the Resources for Integrated Care website. Next, Care Wisconsin will talk about how they have used the tool, and a representative from the state of Colorado and one of their community partners will talk about how they have used the tool. And then, of course, as always, we will conclude with 15 minutes of Q&A. My name is Chris Duff, and I will be narrating the webinar and review the model and revised tool. Elizabeth Brisky and Elizabeth King will present on Care Wisconsin's use of the tool, and Kathleen Holman and Gary Montrose will present on the state of Colorado's use of the tool to further develop their state's disability competency. As with the healthcare system as a whole, the field, we're doing the poll now, I just too caught up in my narrative. So if you would just very quickly respond to this question, we want to get a sense of what context in which people work. Health plan, just choose one of those options, and then we'll quickly go back and look at the results. Okay, let's look at the results. Oh, interesting diversity, I'm pleased. Most of you are in health plan, but we have a good sense of direct provider settings. Advocacy, I'm pleased with. Government, actually, it's a nice diversity. Generally, we have a lot more health plan than the other, so I'm very pleased with that diversity. So on back to the presentation. As with the healthcare system as a whole, the field of care and support for persons with disabilities has been evolving over the last 30 years. The disability rights movement was launched by Ed Roberts half a century ago, precipitating an evolution that continues to this day. Over the years, disability competent care has come to be based on his expectation for equal access in all of its forms. The healthcare system has come to see that each individual has unique needs and are not just a diagnosis. That accessibility is multidimensional and not limited to physical access. And that social determinants of health must be addressed to support self-determination and community access in order to achieve health outcomes. As is evident throughout the model, disability is not understood in terms of a disease process, diagnosis, or injury, but from the perspective of an individual's functional limitations. The DCC model has evolved from a collection of promising practices and processes designed to aid organizations in the delivery of care and supports for persons with disabilities. It has matured to address and incorporate changes in the healthcare system, including the expanded use and role of care coordinators, increased engagement of providers with support, training, data, and accountability, and perhaps what is even considered the secret sauce, which is the ability to integrate Medicare and Medicaid dollars and benefits to address social determinants of health, support independent living, providing the right care at the right time, regardless of payer source. The previous version of the DCC model was developed over 5 years ago and had 3 pillars. Since originally released, we received feedback that it was overwhelming to use, making it challenging for plans and providers to identify priorities for improvement or enhancement. Additionally, since the field is progressing quickly, it was time to update some of the content. The current content has 7 pillars, restructured to make it more accessible, and it now follows a more chronological order of the delivery of care. Most of the content was in the original tool. It's also in the revised version. As you can see here, the 7 pillars. I will not read through them at this point. The tool takes the DCC model of care and transforms it into a self-assessment tool. The goal here is to provide a means for plans and providers to assess their own competency, identify areas of strength, and opportunities for improvement. We do not believe any one plan or provider will ever be 100% disability competent. I know I certainly wasn't, but that it is a continual process of self-examination and improvement. Next slide. The tool consists of a series of questions within each pillar. The accompanying evaluation results form tracks responses and provides a roadmap to identify strengths and opportunities for improvement. We have also provided a user guide to help with the tool, which is also at the RIC website. As I stated earlier, it provides background information for each pillar and a brief explanation of each question. Using the evaluation results form, the pillars are separated in tabs across the bottom of the Excel spreadsheet. You can also download a non-508 version that can be used on paper. For each question, you will be asked to choose among 5 answers. Never, rarely, sometimes, usually, and always. This slide defines each answer a bit further, though I won't review them at this time, but it is included in the user guide. Once all the fields are populated in the evaluation results form, the results summary tab calculates the average response for each pillar and subsection, presenting an overview that may help you and your organization to better prioritize your opportunity areas. This will provide a sense of where you need to begin to focus. Please note, though, that the average response column simply provides an average and doesn't reflect the full range of responses in the section. For example, you may indicate that you usually do the majority of one pillar, but there were a few times that you never do a few individual items. Therefore, we suggest that you quickly revisit your individual responses to each pillar to catch these gaps. Now, I will transition into describing how we suggest you use the tool. As this webinar will show, there are many approaches to using the tool. Organizations and providers and states need to decide which steps and processes best fit their culture, available resources, and priorities. For example, some plans assigned an interdepartmental team to complete the assessment and make recommendations. Others have clinical leadership review the tool and identify areas of focus, while still others have engaged an external stakeholder team or consultants in the process. Though there are multiple approaches to using the tool, the process we recommend is relatively uniform. Identify staff members to complete the DCCAT and its subsection. Have each of those individuals read and answer the question individually or together. Capture the results on the evaluation results form. Have the team review the results and determine priority areas. From there, obtain internal support, reviewing results and recommendations with senior management. Identify improvement team or teams. Develop detailed improvement plans with goals, desired outcomes, and timelines. And then, of course, periodically review the improvement efforts and progress with the larger organization for understanding and buy-in. Again, the tool, user guide, and evaluation results form can be accessed or downloaded as a link on this page. The rest of this webinar will be dedicated to seeing how the tool has been used in two contexts, an individual health plan and a state. I will now turn it over to Chris Brisky for CARE Wisconsin.
Hi, thank you. I just want to start by introducing you to CARE Wisconsin. We're a nonprofit organization that has been in operation since 1976. We originally started off as an adult day center for elderly members in our community. And then in 1995, we were part of a demonstration program with our partnership program, which is a fully integrated acute and primary as well as Medicare and Medicaid program. In 2008, then we expanded our services and started offering services to Medicaid participants in home and community-based waiver systems, so the long-term care services. And in 2014, we expanded into Medicaid SSI. Our current system includes 2,000 medical health and long-term care providers and 700 employees in 2018, the majority of those being involved in care management activities. Our membership includes individuals with intellectual disabilities, physical disabilities, as well as the frail elderly. They all have a complex medical history with many diagnoses and comorbidities and high prescription usage. So the programs that we have, the slide right now demonstrates the funding source as well as eligibility and the type of benefits that are available to each one of those programs. For purposes of this discussion, we're focusing on our partnership program, the FIDA-SNP. That's where our efforts were focused in the use of this assessment tool. Next slide. With this assessment tool, we felt we had an idea of what we wanted to accomplish, and were introduced to the self-assessment tool. So it helped us to identify a course of development of a program related to complex care management, utilizing our interdisciplinary care team. The interdisciplinary care team for the partnership program includes a nurse practitioner, a registered nurse, and a care manager. So they all work together to identify members for this complex care management program, as well as provide a plan of care for those members. We're fortunate at CARE Wisconsin to have an executive team that's highly engaged in quality improvement initiatives and innovative and new ideas for our members, providing quality care for our members.
So that being said, there is a strong drive at CARE Wisconsin to always be looking for opportunities to improve performance. And so the Vice President of Performance Excellence spearheaded a project to improve care management at CARE Wisconsin. And she called in multiple key players at CARE Wisconsin. We developed a work group, and we looked through the DCCAT activity findings and really used that to explore and drive our care improvements. Through the process, CARE Wisconsin decided to focus on a subgroup of high-risk individuals with frequent hospital admissions. This was really our target group because they seemed to be ones that pose some increased risk both to themselves and also to, obviously, costs. And certainly something that the care management group could increase their attention to. So the plan was to identify ways to enhance the care management for this particular population subgroup. Next slide, please. Thank you. So the results were that there was a creation of a complex case management program, and through this, members received a different level of care management and care coordination. The IDT, which again was the nurse practitioner or PA, the nurse or care management, that group, the VP of Performance Excellence and the medical director could identify the individuals or participants that would be involved. And the work groups met frequently, often, and tried to identify strategies to enhance the problem solving around the care that these individuals needed. And that was really the focus of the program. What came out of it was it quickly was really obvious to all of us that we needed leadership. The key feature was to have people who were able to both step up at the highest levels, both organizationally and at the member level. No, that's the right. Yeah, sorry. No, that's the right slide. Sorry. We identified that these were people who would be willing to step up. They would have to be trained in some way and able to meet this higher level of care management. And they needed to address the high-risk member group in sort of a unique way, not the same as what we had done under care management, which is something we're pretty well versed on. At CARE Wisconsin, we decided that would be our NP and PA group. We identified these as the individuals to start that conversation and to provide the structure around complex care. The NP and PA's job was to lead the mission to engage the member and all of the players involved. And this was a process that helped us drive what we call a community care plan and community care teams. So we looked at who was involved in the member's care, what the issues were. We gathered data. We collected information and resources. We looked at who was involved in the care, the supports, the primary care physician group, really anyone who could even be a pharmacist in the medication aspects, but really engaging every single player to be part of this process to make improvements in this particular group's care. And so through, the next slide, please. Through the outreach, member data was gathered, the care plans were created, and this community care plan identified members and their variables, including systems issues, access issues, mental health issues, whatever the situation was. And we created these, a write-up or a care plan, if you will, for all of the individuals who worked with this individual, and we created the care plan, and the plan was organized in a way that it was adaptable. It included the social determinants of health, and it helped us sort of come up with a care plan that was useful, that we could take into the community and we could take into any aspect of the care and use it to make the care better. So once the plan was tested and success was identified, the member's care did return back to the routine level of care management. But the key concept is that it was a different place than where we were before. We were using a higher level care management. There were a lot more variables that were considered in this particular group's care plan. And it was a mission to make the care better And through the process and through the issues or the things that we identified, we were able to make some success through this. So some of the improvement strategies, some of the things that we learned in doing this and using the DCCAT included the need to be more open and flexible and considering new ways of doing things, not doing it the same way, recognizing that there was something unique about this group and that we really needed to do something different in order to make a change and make it better. We also needed buy-in at the highest organization level. We needed a buy-in at the individual level. We needed members or participants to buy into it, and we also needed some community buy-in. It is really important to have at least one person who is willing to step up and champion better individual member care. It seemed to really make a difference. Success leads to improved respect across the board, better care management, and better care access. Other providers, including the primary care providers, importantly, did want to be involved, and what they could offer did make a difference in terms of how things turned out. So never underestimate the involvement of others in terms of making improvements as well. And then finally, member engagement can be a very challenging aspect we found, but there is something absolutely very pivotal about success in this area, and so that is not something to be underestimated. The next steps at Care Wisconsin, things we are still working on or considering is, first of all, trust gained through the process helps members engage, but we are still working on really creative ways to help strengthen engagement. Complex case management resources are consuming, and so the number of participants really need to be limited so that you can be effective. Skill building and tools to improve efficacy are needed. Finally, tools to effectively evaluate how we are doing are needed. Is what we are doing making a difference? And that's really important to us with the goal of reducing member risk. So in summary, involvement in the DCAT did motivate Care Wisconsin to explore and create complex strategies and helped us refine our care management for those with unique needs. So I'm going to pass this on now to Kathleen Holman and Gary Montrose. Thank you.
Thank you, Elizabeth. Greetings from the Rocky Mountains. I'm Kathleen Holman, representing the Colorado State Department of Healthcare Policy and Financing, the State Medicaid Office. I'm here with Gary Montrose, advocate and stakeholder representative lead on the DCCT project and work in our state. Let's jump right in. Next slide. Next slide. Oh, back one. Thank you. Colorado utilizes a managed fee-for-service system where we rely on our regional care coordination organizations, RICOs, to utilize their own care coordinators or network providers to deliver all care coordination services. The state provides oversight, guidance, and monitoring of the RICOs, and the RICOs are tasked to implement all initiatives and projects within our Accountable Care Collaborative, the ACC. They are tasked with 3 priorities. First, the coordination of care. Second, practice support. And third, network development. The RICOs must develop their provider network and establish a beneficial working relationship between the state and their primary care medical providers, PCMPs. Next slide. Here is a visual representation of our structure. The state is involved in all elements, but you can see the touch points between the RICOs, providers, the quality performance metrics, which are outlined in RICO contracts, and our data management system. Next slide.
I think it's my turn to jump in.
Yes.
So speaking on behalf of the advocacy and provider community of LTSS providers, I'd like to jump here and say disability competency care itself as a concept was a major priority and was able to express itself through the Medicare-Medicaid Duals Demonstration Project. As part of that project, Colorado stakeholders had a very strong appetite for improving access to providers for people with severe disabilities. Our DCCT development work occurred during 2015 and 2016. Some of the more and most influential stakeholders included a former ADA regional office director, one of 6 or 7 regional offices around the country, which happened to be housed in our geographic area. Executives from a very mature, robust, independent living center that provides LTSS services to people with severe disabilities and advocacy support, as well as our 7 RICO partners across the state that Kathleen has just described to you. And they performed the care coordination functions across the state Medicaid system. Next slide. Colorado Medicaid advocates and stakeholders worked extremely well together. It was an amazing collaborative experience. It's something that actually is quite common in Colorado, and especially in the healthcare environment, where the department reaches out to consumers, advocates, and stakeholders to solicit our input on virtually every major decision. It's a really wonderful working environment that we have. So they were able to put together a stakeholder work group that was responsible for the design of the Disability Competent Care Clinic Survey, which was the output that we were able to generate after the time we spent together during 2015 and 16 with all the various stakeholders. The work had robust participation and significant research and technical assistance from a number of providers and partners, including technical assistance from the Lewin Group. The survey was built on, our clinic survey was built on the 3 pillars of the Americans with Disabilities Act, and that is addressing physical accessibility, communication accessibility, and programmatic accessibility. Next slide, please.
Thanks, Gary. Ultimately, Colorado did choose to focus on access and primary care for our survey, especially since our managed fee-for-service structure relies on the RICOs and their ability to leverage their provider network. Access in primary care was seen as a gate for starting disability competent care conversations in medical offices. So focusing on physical, communication, and programmatic access within primary care delivery systems was the best way to manage and administer the clinic survey tool for us here in Colorado. Care coordination and patient engagement pillars in the DCCAT are elements of our RICO system, and they are addressed within our survey, but not specifically as a separate pillar. Thus, Colorado strayed from the original DCCAT, but only in practice, not in conceptualization, energy, and overall intended outcome. Next slide.
So the survey tool that we developed drew heavily from other assessment tools, and I think it's important to mention that we're just standing on the shoulders of the giants that had preceded us in the advocacy world. And the 2 surveys that we most leaned on was from California, the California Physical Accessibility Review Survey, and then secondarily the ADA Checklist for Readily Achievable Barrier Removal, a tool that was developed out of the ADA Center in serving the New England states. Our survey development process focused again, as Kathleen mentioned, on primary care. We realized that engaging PCPs would be a challenge. We designed the tool, therefore, to be as user-friendly as possible, framed as an assistive and helpful device for our PCP provider community as a way of meeting the needs of especially vulnerable populations. Our goal was to improve practice accessibility for people with disabilities through our DCCT clinic surveys, with as many practices participating as possible on a voluntary basis. Next slide. Once the survey was rolled out, it was provided to our RICOs as a screening tool to be used in their provider support toolkit. Our aspirational goal was to have all 7 RICOs across the state complete 6 to 8 provider practice surveys over a 1-year period of time. The RICOs had discretion as to how aggressively they chose to implement the clinic survey. Fortunately, one RICO was willing to enter into a contract to fund performance of 12 clinic surveys. And that was a really key turning point in the evolution of our experience here in Colorado. They partnered, that RICO partnered with a very mature independent living center in Colorado Springs with ADA subject matter experts. This team managed to complete 10 surveys of PCP offices in 2 different RICO regions of the state, again focusing on physical accessibility to and within clinic offices. Some 12 targeted surveys were completed in the Colorado Springs area and the second largest population center in Colorado. Although our goal included addressing the communication and programmatic access pillars, we discovered that the practices did not have the bandwidth or willingness to engage in that level of clinic assessment. Without some level of pressure from some government entity, such as the state or Office of Minority Affairs, while avoiding the threat of litigation for ADA incompliance. Next slide.
Ultimately, the survey was distributed as a voluntary measure rather than mandatory, as the state felt we did not have the jurisdiction to enforce the ADA. The voluntary aspect of the tool was the biggest challenge that we faced. There's little leverage for the state and the RICOs with providers to complete the survey. The length of the survey and the provider and RICO capacity to administer the tool is another challenging factor, as well as the flexibility and discretion that RICOs had to implement as much or as little as they saw fit. We had many key takeaways, but those were the primary challenges. Next slide. Of our key lessons learned, we did see the collaborative nature of the survey being its key success, as well as having a DCC expert, content expert, or subject matter expert, or champion was crucial for the DCC clinic surveys to be rolled out within our provider delivery system. It's not just a do the survey and you're done, but an ongoing mindset change and upfront education about disability cultural competence. With that, we were able to see some increase in engagement. Next slide. Continuing here in Colorado, we're not giving up on our survey. We did fund and produce 7 training videos for how RICOs can use the survey at the practice level. You'll see the link here on the slide. We love our videos. We think they're very excellent, and they provide a great deal of narrative and member experience to how important this survey tool really is. We wanted to also provide intrinsic motivation as well as practical application materials and support for how to use the surveys. We included a webinar video directly for our RICOs for options and the flexibility for maybe how they can present that within their RICOs. The videos elaborated on the importance of implementing the tool with providers and focused on provider education and training. We hope to participate in further webinars to provide details of our 2 years of experience and our approach to implementing the survey tool and videos here in Colorado. We are officially rolling our videos out across the state in January. So although they have been completed, we have not had any experience with the reception of the videos yet, but stay tuned. So with that, on that note, I'll turn this back over to Christoph.
Thank you, Gary and Kathleen, very much. I appreciate it. I'm first going to address some process questions we've had. Someone asked where they could have access to the Colorado tools. And just wanted you to know it was on the last, it's on the, nope, it was on the last slide. Jesse or someone, could you go back to the last slide where it did show the link? Yeah, there it is. So you can access it there. And
those are the training videos. Sorry, I believe it was slide 40.
Oh, good.
40 or?
We have them in slide 45. And they're up on the webinar now with the link to that.
And those are our training videos. Our actual survey tool was earlier in the slideshow.
Okay, we'll put them up on our website. So thank you very much. I appreciate your flexibility in letting us do that. And then Sarah Rayner asked kind of the flip side of that, which, and maybe I'm not pronouncing her name right, from the University of New Hampshire Institute on Disability. She wanted to know how she can share some of the resources they've developed on disability competency. And we would love to see a lot of that stuff, and we would love to kind of partner with you in getting some information out. So please contact the contacts at the end of this webinar or anyone at the Lewin group, and we can have a conversation and figure out how to do that. So thank you for reaching out and wanting to help us make use of your values, your valuable material, I'm sorry. And then there's a comment, that less of a question and more of a comment from Kenneth Capron. And the question, I'll read it exactly as is. Usually, when one addresses disabilities, their first thought is of physical. As an advocate for cognitive disabilities and dementia patients, I have to say that understanding and accommodation of dementia lags behind those disabilities, these disabilities that are visible disabilities. I totally think you're right. I agree. We needed to, when we started this, we needed to figure out how could we possibly address all the variable forms of disabilities, especially once you get into the hearing community, deaf community, the deaf community and others. There's just so much more, so many different dynamics. So we chose instead to focus on, I said this earlier, but I want to repeat it, focus on people with functional limitations, not diagnoses, and we're not focusing on age because really one's disability doesn't disappear once you turn 65. So a disability can start early on and can go until later, very late in life. You acquire disability in a variety of places. So I agree with your comment. It's just within our body of work, we haven't addressed that. There is some other material that you can find at the Resources for Integrated Care website that will address some of the other things you're talking about, such as persons with IDDD, such as geriatric population, and so on. So I encourage you to spend some time at that website looking at some of the other resources. So thank you for those 3 questions or comments. They were very helpful. So I'm going to put forward these questions in terms of which organization it references. How did you, and this is for Care Wisconsin, I'm sorry, I should be clear up front. How did you get past the normal resistance to change in your organization?
Hi, this is Chris. Can I repeat the question? How did you get
past in your organization the normal resistance to change that staff has?
So in our this is Elizabeth King, and so in our organization, we are about change.
Mm-hmm.
So that is part of our culture. We embrace that, and we move with that every day. And so that wasn't so much of an aspect for us. It was really trying to answer all the questions that we had to try to make the improvements. I think most of our group was very, very flexible with the change.
That speaks to the culture issues, and I've actually known Care Wisconsin for probably 15, maybe 20 years, and I can vouch to that. They have amazing values, and you see that in the depth of their work, the creativity of their work. So that's great. That's great that you found out how to do that. And if you have any advice for others on that more secret sauce of how do you keep that kind of environment, that would be helpful to share. Go ahead.
Sorry. So yes, I think that is an issue. It's an aspect that we all need to consider in everything that we do like this. Change is something that you have to embrace, and if you don't embrace that, it's not comfortable here. So I would encourage people to start thinking outside the box and embracing change. And the more you do it, the more you want to do it.
That's great. Thank you very much. I love that attitude very much. Another thing that you kind of vouched for, and it was asked about, is about how do you identify people for clients for your CCM program. I just wanted to say, I think it was Elizabeth I was talking to in preparing this. She referenced kind of the sense of, yes, we do look at claims, and yes, our medical director reviews people, puts people forward, but she said it's just as much listening to the staff and having them put forward who they think could benefit from that. So you kind of combine the science with the art being what your staff, your care managers, and others know from their relationships with staff, with the members. Can you speak more on that? I hear many plans try to use their data to find the people who need this kind of touch.
Yes, and I appreciate that question. So we started looking at data, and we were thinking that the data had all the answers. And then we realized that you could actually throw the question out to the team and say, so who is it that you would identify or could anticipate? And from our, lengthy experience, our, culture of change, our culture of problem solving, we have a sense of intuition. Now, whether or not everybody has that, I suspect we all have some. But for us, we could easily identify through just intuition that this one was either there or was heading in that direction. And if we could use that data and combine it with the studies and all the other data that we gathered, it was actually quite impressive how much they match. And that was something that was quite moving for us.
Thank you. That's I've never heard of any plan or provider saying that has been totally satisfied with their data analysis for that purpose. So I appreciate how you try to combine those. Let's go to the training. So you identified some staff, or they identified themselves, who were interested in working on this, such as Elizabeth. Did you do any additional training for other staff who are working doing CCM? And if so, what kind of training was it?
So there were a variety of different things, and we did find that those who were told they were going to do this was a little more uncomfortable than those who were excited about this and saw this as an opportunity. But both ways work, because if you provide some tools, one of the tools that we used was the Wisconsin STAR method, and that was one way to be a member-centered exploration of members' issues, care barriers, mental health issues, whole aspect, and really just a holistic view of the individual. And by using a variety of different tools, we could get to what we saw as the ultimate goal, and that was the care plan that helped eliminate barriers and set up a better way to manage the situation.
Makes total sense. We have a question here from Valerie Merle from Kansas Council on, I can't quite see the rest of that. she says, and I love this because God knows I love her. Seems like a lot of information for an MCO to sort through. Am I really seeing a self-assessment tool is 46 pages? Well, yes, you are seeing it as 46 pages. And that really, at what point, what do you say is not important? So we kept trying to kind of go, detail and higher level. And so that's why we split it up from 3 to 7 pillars. So some organizations are saying, we really, like I believe it was Care Wisconsin, said we want to focus on care management. And Colorado said they wanted to focus on access and primary care. So that's another thing you can do is instead of looking at all of your organization, you can just look at a couple components. In actuality, when I have taken the tool fairly recently in the last several months, I took it and pretended I was in an organization that I'm very familiar with because I haven't been a provider for over a decade. And I could complete it in an hour and a half. The problem is, completing it is one thing. The second thing is then making sense of what you see in the results and then figuring out what you're going to do about it. So it is a bit of a process. Some organizations, and again, we have some different examples here, put together a work group to do it. Some asked one individual to do it and then come up with recommendations, and then a work group came up with ideas to build a quality improvement program around it. So there's a variety of ways you can make it functional. So you don't have to do every single piece of it. We are assuming that most every organization in this space, we're not assuming, I believe it's true, most every organization in this space has some degree of competency. On the other side of that, they're never going to be 100% confident in everything. So you need to figure out where you're going to start, and that will then make it much more doable.
Chris?
Yeah, go ahead.
Gary Montrose, could I chime in?
Yes, please.
Yeah, the fact that there are these 7 different pillars within the self-assessment tool provides a great opportunity to leverage the major lesson learned in Colorado over the past several years of trying to do this work, and that is that to try to get practices to become ADA compliant and the 3 concepts that we talked about, program, physical, and communication accessibility, those are technical issues that require a lot of work and expertise. Our major lesson learned was that disability cultural competency needs to come first. They need to understand what disabilities are. What do we mean by disability cultural competency? To treat people with respect and dignity and address the physical challenges that they face, which are all addressable. But most practices just don't know, and they don't even know that it's an issue. So starting off with low-hanging fruit, with some small steps, some easy wins, and just having people understand what the issue is seems to be the right place to start, and hence the development of the educational videos that the good state of Colorado Medicaid has funded and is now available for everybody to use. So that was our major lessons learned about where to begin in the 7 different pillars.
Thank you, Gary, very much. I appreciate that. I would also ask everyone, if you can, download the full DCAT from the RIC website and complete the survey related to that. We would like to get as much feedback on it. As with disability competency within a provider or plan setting, we are never fully competent in the disability competent care model. So we really would love more feedback from you as we go along here. Okay, so another question that came in. Okay. We have care coordinators function in many of the pillars. Why did you separate this function, care coordination, into its own pillars. And I think that's a question for me. We had to kind of put it, and you're right, care coordination more than anything really goes across most all of these, because that's generally the person who touches the individual, the participant the most. So we didn't want it to get lost under primary care or access or LTSS or behavioral health. So that's why we pulled it out into its own individual pillar. Gary or Kathleen, I think it was, you talked about the advocate's role in the process and identification of the priorities, and we saw which priorities you came up with. Are you all still, what is the role, I think the question is, what's the role of the RICOs in continuing to administer the surveys, and what's the role of the stakeholders, either as a group or individually, in continuing to work towards disability competency? So I think that's a question for the woman from the States whose name I'm blocking right now.
Yes, thanks, Chris. This is
Kathleen.
Kathleen.
I'm sorry, yes.
I'll address the RICO side of it, and Gary, if you'd want to address maybe the stakeholder and advocate side of it, let's do that. So the RICOs have three main tasks, and they are tasked with the priority of coordination of care, practice support, and network development. We really allow as much flexibility as we can for each RICO across their region to amend and adapt to their providers' needs, and also to support their providers in their practices. So there has been quite a bit of leeway that we have provided the RICOs for how to do this. Again, it was a voluntary measure, so we are hopeful with the videos that this will continue the DCCT conversation that started 2 years ago, and really encourage the RICOs and providers. So the RICOs provide support and oversight, and the providers, kind of feed from that, and that's where they're getting the state message. And we have very clearly outlined that this is a priority, and the RICOs know that it is a priority. So it's just part and parcel of the work that they're doing, and but ultimately we know that sometimes the burden of care falls onto the providers themselves. And so in our videos we did try to outline specific tasks or activities that providers can do themselves. So it might not need the RICO support in order to just look at the videos. And we encourage our providers to do that themselves if they feel that they can. So the clinics are really able to get feedback and support from the RICOs, but they're also very able to go outside of that relationship to get their needs met, and especially if they're meeting the needs of their members as best as they can. So that was the RICO part of that. Gary, do you want to speak to the stakeholder?
Yeah, let me, from the voice of the stakeholder and the LTSS provider community, it's important to call out that the RICOs, the relationship between the RICOs and the states involves a contract. That contract says that the RICOs must comply with all state and federal regulations. That would presumably include the Americans with Disabilities Act. But the fact that the state and no one else feels that they have the legal authority to enforce that means that nobody's obligated to really become fully accessible. So we as stakeholders try to keep our foot on the gas pedal, pumping it all the time and putting pressure on the state and the RICOs to remember that there's a vulnerable population that is not getting the kind of health care that they need and deserve. So those are the real obligations between the state, the RICOs, and the stakeholders. And it takes all three of us working together to get some kind of a positive movement in this challenging issue.
Thank you both. I appreciate that. I also want to note that I believe it's one of the early webinars in our next series, which will be starting in February, where we're going to be actually talking more about Colorado's experience with their site survey and be learning from a few other places on this very issue. So stay tuned, please. Okay, before handing this back to Jesse, I would like to make a few brief concluding remarks. First, the tool is not meant to be proscriptive, but suggestive. And users need to bring their own judgment to the assessment. Secondly, the DCC model is conceptual in nature and needs to be adapted locally based on your capacity, priorities, and population. Lastly, we don't believe any provider or plan will ever achieve total disability competency. Instead, we see it as a process, and we're challenging people to continually focus on it. Some gaps will be able to be addressed fairly simply, while others will take a major quality improvement initiative. So at this point, I'm going to turn it back to Jesse to wrap up.
Thank you, Chris. Thank you to our presenters today, and thank you all for attending and your contributions to our discussion. Please feel free to continue to send any additional questions either via the chat on the platform or to our email address that will be posted at the end of the presentation. We'll be sure to follow up with you. As Chris mentioned, we are excited to announce our new DCC webinar series that will begin in February 2018. We'll be doing a deeper dive into the DCC model concepts and bringing you leading practices from experts in the field. Registration information will be sent to your inbox for all those registered for today's webinar, and of course, they'll be posted on our website, resourcesforintegratedcare.com. As always, your input is essential in developing new trainings and resources. Please answer our brief survey that will appear automatically on your screen when this webinar ends. And again, you can send any additional comments to our inbox, rick@lewin.com. That's RIC@LEWIN.com. And finally, you can access the DCAT that we talked about today and many other resources at our website as well. Please visit resourcesforintegratedcare.com and you can see all of our disability competent care resources hosted there. Once again, thank you for attending today's webinar and have a great rest of your day.